Hey, Dr. Frank from IDN with another clinically relevant. This one's called When Heel Pain is Not Plantar Fasciitis. This is a case study of a 17-year-old male lacrosse player who just started back at the upcoming season doing conditioning. And he had no prior issues with his foot or his ankle, but he started getting symptoms of tingling and burning onto the medial aspect of the foot and into the heel, mostly with the activity, but also by the end of the day, he was pretty sore. One thing of note, he was wearing his cleats from last year, which we'll talk about. But essentially, the lumbar exam was negative, other than the fact that when I did a straight leg raise with him, and we had a little bit of dorsiflexion and eversion, I got a reproduction of symptoms into that plantar surface. He was also real tender with palpation down the inferior calcaneal nerve path. So when we start looking at this limited evaluation that you're seeing is what kind of diagnosis are we looking at? Well, what stood out to me was Baxter's nerve entrapment right off the bat, and it's also called inferior calcaneal nerve. So let's talk a little bit about the anatomy. As we look at the tibial nerve anatomy, the nerve comes down on the posterior aspect of the tibia. It travels underneath the flexor retinaculum, where it splits into the medial and lateral plantar nerves. Now, before it does that, it sends a sprig off here, which is called the medial calcaneal nerve, which is responsible for a lot of the medial side calcaneal pain or heel pain that a lot of your patients present with. Both of the nerves sort of travel down further into the foot. In particular, this is the abductor hallucis. So I'm going to remove that. We can see very clearly that the medial branch heads down, and then the lateral plantar branch heads deeper and towards the lateral side of the foot. Now, there's one additional branch here coming off the lateral plantar called the inferior calcaneal nerve, or the Baxter's nerve, is which we're going to be talking about. Now, Baxter's nerve travels between the abductor hallucis and the quadratus plantae, and it's actually an area where it can be entrapped. It continues posteriorly to go underneath the flexor digitorum brevis and continues around on top of the quadratus plantae. It actually passes the medial calcaneal tubercle, which is another area between the flexor digitorum and the quadratus where it can be entrapped. And it continues to head further laterally to innervate motor-wise the abductor digiti minima. So let's take a look at needling of a Baxter nerve entrapment.
Right off of the bone, this Baxter's nerve will continue underneath the foot. So my assessment of this is going to be literally a nerve palpation as I'm traveling around, coming underneath the foot. Now, we get a little bit confused through here because this is where the plantar fascia is. So there can be an actual plantar fascia problem. There can be a tubercle problem, a tuberosity problem. So there's a number of things that can be going wrong. But I know for a fact that when I'm tender here, I'm mostly on that Baxter nerve, right? So that's where I'll begin my needling, right under the abductor hallucis. Now, I've got a 1-inch needle. I can go longer, I can go shorter, depending on the size of the foot. So I'm going to find the navicular, right? I find the navicular, and between the navicular and the end of the calcaneus is that space where that Baxter's nerve runs down through. So essentially, I'm going to go ahead and needle coming down through. So from a needling standpoint, you continue down the nerve distribution, certainly by the abductor coming around the corner. You can even come underneath the foot itself, but a lot of patients don't really like needling on the plantar aspect of the foot. So I like to come in from the side, which is usually better tolerated.
So from a clinical standpoint, they say that Baxter's nerve entrapment accounts for about 1 out of 5 hindfoot pain cases. So it's not really diagnosed all that much. And I think a part of the problem is that it has an overlap with other common foot pathologies like plantar fasciitis, as we talked about. So I think that's one of the issues that we deal with. But what's interesting is I think part of his issue was that those poor cleats really created a lot of irritation, and he essentially had neurogenic inflammation. And what neurologic dry needling allows us to do is reduce that inflammation right off the bat. And again, that's only one part of it, helping with pain. The other things that we obviously have to do in this case, and we did, was look at manual therapy. You want to get the joints moving, you want to get the soft tissue around that area moving, you want to give corrective exercise as we go along. And then certainly in this case, educating on proper footwear and training education is something that would be valuable for this particular individual, and it was. Hope that helps. Hope you enjoyed it.